introducing our speaker for today, Dr. Francesca Khani. She's an assistant professor of pathology and urology at Weill Cornell Medical College in New York City. She graduated from the College of New Jersey with highest distinction and then matriculated at Rutgers Robert Wood Johnson Medical School, also in New Jersey. She went on to complete her APCP residency at Weill Cornell, and that was followed by a clinical and research fellowship in urologic pathology at Johns Hopkins. Following her fellowship, she returned to New York City as faculty at Weill Cornell New York Presbyterian Hospital. And in that short time as an assistant professor, she's received numerous career development awards, and her research is currently focused on the molecular characterization of prostate cancer. So we're really pleased to have her with us today for our first virtual pathology grand rounds. And with that, I will send it over to Dr. Khani.
First of all, hi everyone. Thanks for participating in this inaugural Grand Rounds. I'm really honored to be the first speaker to participate in this. And before I start, I really want to acknowledge the work that our clinical colleagues are doing at this time on the front lines of this pandemic, as well as our clinical pathologists who have been working to ramp up testing for COVID-19 across the country. My thoughts are really with them constantly, but I am hoping that this talk will serve as a bit of diversion from the current situation right now. I know we have I think we have a pretty diverse audience in terms of trainees, pathology faculty, maybe some basic scientists. So I think, there's a little bit in here for everyone. And I think it's for those of you who do have expertise in geopathology, a lot of this probably will be a bit of a review. But I hope you find this topic as interesting as I do. So, okay, so we'll get started. Second. Okay, so we're talking about the evolution of intraductal carcinoma today of the prostate. Here's an outline of what I'm going to be discussing. So I'm going to talk about the evolution of intraductal carcinoma from a pathogenesis perspective during this talk, but I'm going to start by actually discussing its evolution as a diagnostic entity from a historical perspective. We'll then move on to the differential diagnosis and pitfalls in diagnosing this lesion, the evidence we have for its pathogenesis, and also the subsequent issues that arise with reporting and grading with regard to this lesion. Finally, I'd like to share with you some of the current research I'm pursuing in this area. So from a historical standpoint, I think this is pretty interesting. Actually, intraductal carcinoma dates back to 1909. This was really when the first report of this was recognized by a pathologist named John Geraghty. He was working in the surgical specimens of Hugh Hampton Young, who was a surgeon. And Young acknowledged the microscopic observations of his pathologist colleague, that cancer in the prostate spreads in two directions. Basically, that extends from the ducts into the stroma, but also from the stroma back into the ducts and by extension along the ducts. And he described masses of cancer cells filling the acini. This is one of the images from this paper, where we see intraductal carcinoma that looks just like what we described today, and we'll talk about later. And then fast forward about 70 years later, and this is one of the earliest reports in the contemporary literature, where 1985 by Covey et al., intraductal carcinoma was reported as ductal spread. And it actually, again, remember, this predated the recognition of prostatic intraepithelial neoplasia, which is our precursor lesion to invasive prostate cancer. This report, in this study, they studied 139 specimens involving TURPs, biopsies, suprapubic prostatectomies, and they also concluded that prostatic carcinoma cells can penetrate the basement membranes of benign ducts and replace the normal epithelial elements, similar to the 1909 study. Here are some photomicrographs of this paper. We can see prostatic cancer cells filling the ducts completely in this duct, and you can see the nice basal cells lining the periphery of this lesion. Same here, dense cribriform pattern. This is a solid pattern. Dense cribriform pattern was lined by basal cells. So another early report of this was in 1996 by McNeil et al. This is one of the more familiar studies that people tend to cite. And he looked at morphologic and clinical correlations of intraductal carcinoma and used immunohistochemistry to determine the presence of basal cells. They found that both the frequency and the extent of intraductal cancers among 476 cases increased sharply with increasing cancer volume. So this was one of the first studies that has started to show that this was associated with worse prognosis in prostate cancer, or just a more advanced disease. Intraductal carcinoma, they also noticed, was frequently seen adjacent to Gleason pattern 4, and that often showed a cribriform pattern. So that was also noteworthy in this study. So fast forward to today, what we now know, and this has been in a ton of literature, we now know that intraductal carcinoma of the prostate is associated with high-grade invasive cancer that has high stage and high volume of disease, as well as adverse prognostic factors and worse clinical outcomes. Also, I think, to keep in mind that a lot of those earlier studies that studied intraductal carcinoma, they saw a lot of it because this was the era before PSA screening, before the early 90s. And so you saw cases that presented at a lot more of an advanced stage. And so intraductal carcinoma was seen more frequently back then, although it is still very common today in advanced prostate cancer. And so despite recognition in the literature over 100 years ago, intraductal carcinoma actually was only as recently as 2016 became recognized as an official entity in the WHO with an official definition. I think this is likely attributable to its increased recognized prognostic significance, and it's kind of like a biomarker in some ways for poor prognosis. So the diagnostic criteria for intraductal carcinoma has been refined in recent studies, and it now includes lesions where malignant epithelial cells fill large acinine prostatic ducts with preservation of basal cells. And also, you should see a solid or dense cribriform pattern. Ideally, more than 70% of the lumen should be filled with tumor. Or if you don't see solid or dense cribriform pattern, a loose cribriform or micropapillary pattern that either has marked nuclear atypia, so you want to see nuclear size 6 times size of normal, or comedonecrosis. So looking at some examples, this is a nice example of intraductal carcinoma with a dense cribriform pattern. You can see more than 70% of this duct is filled with tumor. And in the bottom right, we have high molecular weight cytokeratin lining, showing basal cells lining this lesion at the periphery. Another example of a dense cribriform sort of solid pattern and some comedonecrosis seen on the left here. And again, this is a PIN4 immunostain showing basal cells at the periphery, highlighted by high molecular weight cytokeratin and P63 and racemase staining the tumor. And then on needle core biopsy, again, a sort of dense cribriform pattern. Sometimes it can be really hard to tell whether this is intraductal or invasive cribriform carcinoma, and immunostains can be helpful. I don't recommend doing this in every case when you don't have clearly invasive high-grade cancer, but we'll get into that a little bit more later. But here we see a nice PIN4 stain showing that all of these large nests of tumor are intraductal because we see basal cells lining them. And then here's an example of the other architectural pattern of intraductal carcinoma. This would be a loose micropapillary pattern. And we see comedonecrosis in here. And so that also meets criteria for intraductal carcinoma. And another example of a micropapillary pattern and in this one, instead of, well, there's a little bit of necrosis, but there's also nuclei that are more than 6 times the size of the cells in the stroma. And so this is another example of intraductal carcinoma, just a different variant. Again, lining by high molecular weight cytokeratin, highlighting the basal cells at the periphery of the lesion. So moving on to the differential diagnosis and pitfalls of this lesion, which I think are really important clinically. And in the differential, we have high-grade prostatic intraepithelial neoplasia, which does share a lot of architectural cytologic features to intraductal carcinoma. Cribriform acinar adenocarcinoma, we kind of already just mentioned that you have invasive cancers with cribriform morphology, and those without basal cells are just graded as Gleason pattern 4. Ductal adenocarcinoma is another morphologic variant. And also to remember intraductal, I put this in quotes, intraductal urothelial carcinoma on the differential, because when urothelial carcinoma is in the prostate and spreads down the prostatic urethra, it can expand and distend the prostatic ducts in a very similar way that intraductal carcinoma does. So first we'll talk about high-grade PIN, and just remember this is the only accepted precursor lesion to invasive carcinoma. So the shared features between intraductal carcinoma and high-grade PIN, there's several that are similar. So cytologically, we see nuclear enlargement, hyperchromasia, and enlarged nucleoli that are both seen in high-grade PIN intraductal carcinoma. And architecturally, in high-grade PIN, you can also see a loose cribriform or micropapillary pattern similar to what you see in intraductal carcinoma, although you should never see necrosis in high-grade PIN or nuclear atypia that is more than 6 times the size of normal. These are some examples of the different morphologies that you can see in high-grade PIN. So a micropapillary pattern on the top left, a flat high-grade PIN pattern, a little bit of tufting in panels B and C. And on the bottom right, an example of cribriform PIN. And notice that as opposed to the dense cribriform pattern that you see in intraductal carcinoma, cribriform PIN typically has a loose cribriform pattern. And so at low magnification, when you are diagnosing high-grade PIN, you really want to see the cells the high-grade PIN should stand out at low magnification. And you can see this tufting and basophilic appearance at low power in core biopsies. There's a benign gland here on the bottom right for comparison. So these look a lot more blue, a lot more pseudostratified in comparison to benign. And then at higher magnification, you should see prominent nucleoli. They should be really large and usually extending to the top of the to the lumen of the gland. And these would be diagnostic of high-grade PIN. So the distinguishing features, which I kind of mentioned already, between intraductal carcinoma and high-grade PIN are really the markedly enlarged nuclei. If you see those, cheminonecrosis, or a solid dense cribriform architectural pattern. Once again, just in comparison, a dense cribriform or solid pattern seen in intraductal carcinoma in this example I showed before, and in comparison to a very loose cribriform pattern that you can see in high-grade PIN. So sometimes I think, it can get a little tricky. This is an example of a core biopsy where on the bottom left here, if you just had this area here with a lot of prominent nucleoli and some hyperchromasia, you might think this is just high-grade PIN. But then on the top right over here, you have this a little bit more of a denser cribriform pattern. And it does look like it's all part of the same process. So I would say this is somewhat borderline between high-grade PIN and, but it's not exactly quite as dense enough to maybe call intraductal carcinoma on a core, especially with such a low quantity. So again, in comparison to a very loose cribriform pattern, this is somewhat denser, but it's also not as dense as the dense cribriform pattern that you typically see in intraductal carcinoma. So I think these cases actually do present a bit of a problem sometimes when you encounter them on biopsies. And so what do you do when the features are borderline? So when these features are borderline between high-grade PIN and intraductal carcinoma, the terminology that's been proposed is atypical intraductal proliferation. And you can use this in your reports, and you can even, I usually put a note that says that describes this as being borderline between intraductal carcinoma and high-grade PIN, where that's really the differential and we can't determine which one it is. But the main, no matter how you kind of phrase your note here, I think the main thing you want to get across is to strongly recommend to your clinician to a repeat biopsy. The point being that we can't really tell if this is intraductal carcinoma or high-grade PIN, and if it is intraductal carcinoma, it is associated with very high-grade aggressive cancer, which we don't want to miss. So encouraging your clinicians to strongly repeat biopsy these patients if there is no other core with invasive cancer would be recommended here. So I also want to talk about some of the benign mimics of high-grade PIN, because these can also mimic intraductal carcinoma. One of the big ones, and these are just pitfalls to avoid in general, especially in biopsy cases that don't have any invasive cancer. Again, remember that if you overdiagnose high-grade PIN, if you overdiagnose intraductal carcinoma, the patient could get definitively treated, and so you want to make sure that that diagnosis is certain. But if you overdiagnose high-grade PIN, the patients may continue to get rebiopsied, and biopsies do have associated risks. So not overdiagnosing any of these benign entities is critical in core biopsies. So the three main benign mimics are central zone histology, clear cell cribriform hyperplasia, and basal cell hyperplasia. Central zone histology is really important. I always want to come back to reviewing the anatomy of the prostate and where the central zone actually is. And so the central zone is the area right around it's right around where the seminal vesicle enters the prostate and comes into the prostatic urethra. So this area right around there in the posterior region of the prostate is where the central zone is located. And the histology in this area can be a little funny sometimes. At low power, you might think this has a sort of a pseudostratified look to it. It might stand out as being very cellular. But notice here, this is just an example of central zone histology, that there's very eosinophilic cytoplasm and very tall pseudostratified epithelium. And sometimes you can see these Roman bridges here as well. So a little bridge here. And at higher magnification, we can see that the nuclei are streaming along these bridges. They're kind of not very rigid, like you get in a cribriform pin or intraductal carcinoma. And you can also see a prominent basal cell layer with nucleoli at the periphery. Notice that the nucleoli don't really go to the lumen or all the way to the center of the ducts like you would see in high-grade pins. So you don't see them present throughout all the layers, although you may see a prominent basal cell layer with nucleoli at the periphery. This is another example of central zone histology. It can look a little bit funny with these Roman bridges. Again, this is all just part of normal histology of this zone, which I think is often mistaken for high-grade pin. And once again, looking at high power, we don't see any cytologic atypia here, and the nuclei are streaming along these Roman bridges. Another benign mimic of intraductal carcinoma and also high-grade pin, is clear cell cribriform hyperplasia. This is an example. Here we see a dense cribriform pattern here, which can really mimic intraductal carcinoma. But this is, again, a benign hyperplastic process. Clear cell cribriform hyperplasia. It often occurs in the transition zone of the prostate. I guess this is another example of clear cell cribriform hyperplasia with this bridging and cribriform pattern. And what's important to notice is that at higher magnification, we don't see any nuclear atypia as you would in high-grade pin or intraductal carcinoma. So very bland, cytologically bland nuclei. Another benign entity that often occurs in the transition zone as well is basal cell hyperplasia. And this, you can see, usually you see a tiny, small, solid nests of cells, and they have very prominent nucleoli that can stand out and be mistaken for high-grade pin or a solid pattern of intraductal carcinoma. Again, we can see the prominent nucleoli, and also how you distinguish these. The nests are typically smaller in basal cell hyperplasia than in intraductal carcinoma or even in high-grade pin. Also, the nuclei themselves have more of a blue-grayish hue to them, and they're not as dark and hyperchromatic as you see in intraductal carcinoma. Another example just at higher magnification where you can see that blue-gray hue to the nuclei. And also just another pitfall here is that basal cell hyperplasia can be very florid. And this is an example of florid basal cell hyperplasia where we see a pseudo-cribriform architecture here. Even at low power, you might think this is a dense cribriform pattern in some of these ducts, and even some solid, more solid growth, a more exuberant pattern of this. And this, again, is completely benign. If it's well circumscribed and with no features of malignancy, this is just basal cell hyperplasia, but it can be a mimic for intraductal carcinoma as well. Again, at higher magnification, the trick is to going high power on these lesions, and you see no nuclear atypia. You also see nuclear streaming and overlapping, which also points to it being benign. And again, that sort of pale blue-grayish hue to the nuclei themselves. And so basal cell hyperplasia and clear cell cribriform hyperplasia both occur in the transition zone. So I always like to say, watch out for those TERP specimens. The TURP specimens for BPH are sampling the transition zone, and that's where all of these mimics occur, and also adenosis, which mimics just conventional prostate cancer. And of course, the cautery artifact doesn't help here, so you want to be very careful in diagnosing potentially intraductal carcinoma in a TERP specimen, because a lot of these mimics do occur in this region. This is an example of clear cell cribriform hyperplasia, and it's cauterized here, so it can be a little difficult to tell, to really assess the cytology. Luckily, here we have some more well-preserved areas of the lesion that you can tell are cytologically bland. So moving on in the differential diagnosis of intraductal carcinoma, Cribriform acinar adenocarcinoma, I'm not going to really spend too much time on this because the distinction between invasive high-grade cancer, this would be Gleason pattern 4, isn't that significant in distinguishing it from intraductal carcinoma when there is abundant high-grade cancer present. But essentially, Cribriform acinar adenocarcinoma that's invasive just lacks a basal cell layer, and it does look a lot like intraductal cancer because of that Cribriform pattern that you can have. So again, most cases it's not necessary to do immunostains to distinguish Cribriform invasive cancer from intraductal when you have a lot of invasive cancer in the background. But just to know that that's another morphologic thing that mimics intraductal carcinoma. So I do want to spend some time on this other morphologic variant, which is ductal adenocarcinoma. I think this can be a little bit confusing. I get this question a lot from my clinical colleagues at Tumor Board, and when they're looking at my reports, and they'll say, wait, isn't ductal adenocarcinoma the same as intraductal carcinoma? They sound the same, you know? And my answer to them is typically no. They are different morphologically from our perspective, but I usually say to them, for clinical purposes, it's kind of a yes, because they're both associated with aggressive disease, and that's really the point that you want your clinical colleagues to understand, that ductal adenocarcinoma and intraductal carcinoma are associated with advanced high-grade disease. So if these are seen in core biopsy specimens, they often portend a worse prognosis or just advanced stage and grade at prostatectomy. So intraductal carcinoma versus ductal adenocarcinoma. Ductal adenocarcinoma can have cribriform architecture with slit-like spaces, but it has pseudostratified columnar cells as opposed to the cuboidal cells, acinar morphology that you see in intraductal carcinoma. Ductal adenocarcinoma also will typically have or often have papillary fronds, so true fibrovascular cores, which you usually don't see in intraductal carcinoma. And you can see basal cells surrounding areas of ductal adenocarcinoma. This can grow within the ducts as well, but not always, and oftentimes it's invasive, actually more frequently. So here's an example of a ductal adenocarcinoma. We see nice pseudostratified nuclei around true fibrovascular cores here. Another example of fibrovascular cores lined by pseudostratified epithelium. In this instance, this ductal adenocarcinoma almost has a villus adenomatous pattern. You might think of a GI primary, so always good to rule that out as well. But this is just another pattern you can see in ductal adenocarcinoma. And then another pattern you can also see is cribriform architecture, but which we see these kind of slit-like spaces in the tumor. But notice you still see this pseudostratification of the nuclei, which is characteristic of ductal adenocarcinoma. So I think that this terminology is extremely confusing, not just for our clinicians, but also for pathologists. And I think that, in clarifying this, one way to think about it is that intraductal carcinoma really, we refer to acinar morphology, and the ductal in this word, in this sort of term, really refers to the location. So the tumor has acinar morphology and it's growing within the ducts and acini, where ductal refers to the location. When we talk about ductal adenocarcinoma, ductal morphology, the ductal in this term actually refers to the cytology of the cell. So you want to see tall pseudostratified columnar cells. And again, these lesions are typically invasive, but they can also be growing within the ducts and acini. So the ductal in this term really strictly refers to the cytology and not where it's growing. I think that's one way to kind of clarify. I think it helps me to think about this to these terms. But I think, ductal adenocarcinoma used to be called the endometrioid variant, and we don't call it that anymore, but it's one way to think of it, that these do look like endometrial, a little bit more like endometrial cancers of the uterus. So the last entity on the differential here of intraductal carcinoma is intraductal urothelial carcinoma. Again, I put this in quotes, so it's really just urothelial carcinoma growing within the prostatic ducts. This is a very, very important distinction. The treatment is extremely different between intraductal carcinoma of the prostate and intraductal urothelial carcinoma, where you would get potentially neoadjuvant chemotherapy and a cystoprostatectomy, which is very different from radiation therapy or prostatectomy for prostate cancer. So definitely something that you don't want to mistake. In urothelial carcinoma, there are a lot of overlapping features, as I'll point out. You often have solid nests. Occasionally, you can see solid nests in intraductal carcinoma. In urothelial carcinoma, you often see more marked pleomorphism of the nuclei, but again, one of the patterns you can see in intraductal carcinoma is having marked pleomorphism. So there are definitely overlapping features, and I think the best way to distinguish these when it's not clear is using immunohistochemistry, so prostatic markers and urothelial markers. This is an example of a urothelial carcinoma showing these large, solid nests growing into the prostate. There's even some necrosis here, but again, you can have a solid pattern in intraductal carcinoma, so it can be tricky. At higher magnification, we see a lot more pleomorphism to the cells than you generally see in intraductal carcinoma of the prostate, but again, you can have variants that have, you can have patterns that have that marked nuclear atypia. A lot of mitotic figures are usually more commonly seen in urothelial carcinoma. And again, more prominent nucleoli, you can see in both. This is just highlighting another example of urothelial carcinoma with marked nuclear pleomorphism. And on a stain, on an immunostain for high molecular weight cytokeratin, these are typically all positive, whereas prostate cancer would be negative and just highlighting the basal cells. This can be a pitfall though. This is another example of urothelial carcinoma in the prostate, again showing some really dense chemotonecrosis here with a solid pattern. Higher magnification, once again, that marked nuclear pleomorphism, a lot of prominent nucleoli here. And on this immunostain, I think this would be a reasonable case to stain because it can be a little tough to tell whether this is prostate or urothelial. The high molecular weight cytokeratin is actually negative. And so this is a pitfall. This is staining just like a prostate cancer would if you stained it for high molecular weight cytokeratin. And just remember that a third of cases of urothelial carcinoma will be negative for high molecular weight cytokeratin. So I do highly encourage you doing multiple markers and doing more sensitive and specific ones. GATA3 is the more sensitive marker for urothelial carcinoma. So this tumor was positive. Strong nuclear positivity, and was negative for NKX 3.1, which is a very sensitive marker for prostatic carcinoma. So again, I just want to emphasize on this differential of intraductal carcinoma that high-grade PIN and urothelial carcinoma are have the most significant clinical implications in distinguishing them from intraductal carcinoma because the treatment is completely different. So these are the ones that you definitely don't want to miss or mistake for intraductal. So I'm going to move on to the pathogenesis of intraductal carcinoma of the prostate, which is also an evolving concept. The etiology hasn't entirely really been proven from a molecular standpoint, but I'll discuss the current literature in this area and also look at the molecular features and the clinical implications of this lesion. So the pathogenesis of intraductal carcinoma, which I had alluded to before in the very, very early literature, it's believed to arise by a re-entry of high-grade invasive carcinoma into pre-existing prostatic acini and duct. So here this is my little schematic for high-grade invasive cancer. This is symbolizing a dense cribriform invasive cancer, and this is a solid nest of cells. So this is basically Gleason patterns 4 and 5 that are invasive. And it's believed that these high-grade invasive tumors go back into the prostatic duct acini system and spread along the ducts and form this intraductal carcinoma. The morphologic evidence for this, of course, is that most cases with high-grade invasive cancer, most cases with intraductal carcinoma have high-grade invasive cancer in abundance and have high pathologic stages and in radical prostatectomy specimens. Molecularly, there is also some evidence that intraductal carcinoma does represent retrograde spread of tumor. Some of these earlier studies in the early 2000s by Dawkins and Bettendorf, they showed that 29% of Gleason pattern 4 cancers and 60% of intraductal cancers demonstrate loss of heterozygosity of certain microsatellite markers, and that same loss of heterozygosity is rarely observed in high-grade PIN or any kind of Gleason pattern 3. So just showing that intraductal cancer is definitely more advanced than high-grade PIN or low-grade cancers. Chromosomal imbalances have been identified in intraductal carcinoma compared to none seen in high-grade PIN typically. And then getting into some of the more, one of the more recurrent genomic alterations that we know about today in prostate cancer, and talking about ETS gene rearrangements. Now, ETS gene rearrangements are gene fusions that involve a particular group of genes, and they're present in about 50% of prostate cancers overall. So about half of prostate cancers will have an ETS or ERG gene rearrangement. And the way this works is that there's a gene fusion that results in the ERG oncogene fusing with an androgen-regulated transcriptional promoter, and that results in putting this ERG gene under regulation of circulating androgens, and then it becomes overexpressed. So you can determine the presence of ERG overexpression or an ETS gene rearrangement, those are almost synonymous, by FISH, by seeing if they actually have the gene fusion. But given that this always puts ERG under this regulation of androgens, ERG, the protein will always be overexpressed in the cases with these gene fusions. So IHC, immunohistochemistry for ERG, is a really great surrogate for determining whether that gene fusion is present. And so again, present in half of prostate cancers overall, ERG overexpression or ETS gene rearrangements are seen more often in, or slightly more often in, intraductal carcinoma. So these 4 studies here looked at the presence of ERG rearrangements either by FISH or immunohistochemistry, and they found slightly higher, up to 75% of intraductal carcinomas showing ERG rearrangement. Again, this is an example of the nice immunostain showing nice nuclear positivity for ERG, symbolizing the presence, signifying the presence of ERG rearrangement or an ETS gene rearrangement. Another recurrent alteration that we see in prostate cancer is PTEN loss. PTEN genomic deletion in prostate cancer has been associated with a lot of poor prognostic findings, higher Gleason score, higher rate of metastasis, androgen independence, and overall poor prognosis. PTEN loss, so this gene genomic loss is typically seen in cases that have ERG rearrangement, not always, but you typically do see these together. So you typically have an ERG rearrangement occurring first, and then a PTEN loss genomic deletion occurring later as the tumor develops. And once again, in intraductal carcinoma, not surprisingly, we see a much higher rate of PTEN loss because this does signify an advanced lesion. Up to 84% of intraductal carcinomas in this study were found to have either complete or partial loss of PTEN protein. So again, you can look at immunohistochemistry as a surrogate somewhat for a genomic deletion. And in this, actually this image here, you can see that PTEN is represented in brown, and ERG is a dual stain for ERG and PTEN. So this case does not have ERG expression, but it does have PTEN loss. And in this case, we have ERG expression with the purple staining of the nuclei, and we also have some partial loss of PTEN. So you can use immunohistochemistry as surrogates for these genomic alterations. What's important to know here, though, is that PTEN loss is never seen in isolated high-grade PIN. So if you look at some studies cited here with radical cystoprostatectomy specimens with no invasive prostate cancer that have been entirely submitted, when there's high-grade PIN, you will never see PTEN loss. So again, this is an aberration that's seen in more advanced prostate cancers and never in a pure precursor lesion like high-grade PIN. So some have thought, can ERG and PTEN be used diagnostically? I mentioned before that sometimes you have these borderline lesions on core biopsy that are kind of between high-grade PIN and intraductal carcinoma, and can ERG and PTEN potentially be helpful? It's potentially, these immunostains would be useful in distinguishing intraductal carcinoma from high-grade PIN. As you can see in the study, none of the high-grade PIN samples had PTEN loss or ERG overexpression, and in comparison to the frequent presence of these alterations in intraductal carcinoma. But when you look at borderline lesions on core biopsy, there is some variable, you do see these genomic alterations variably. So it's not going to be as useful for distinguishing borderline lesions, unfortunately. But nonetheless, if you were really between high-grade PIN or intraductal carcinoma, they could potentially be useful. So more molecular evidence for intraductal carcinoma representing tumor progression. And when I say progression, I just mean invasive cancer going back into the ducts as a secondary event. This was a great study by Hafner et al. From the Hopkins group, showing molecular evidence that invasive cancers can actually, that not only that intraductal carcinoma actually represents retrograde spread. They did this, they demonstrated this by looking at PTEN and ERG once again, and showed that PTEN loss they kind of can show the timing of when the ERG overexpression happened and then PTEN loss, and then they saw this same clone of cancer enter within the ducts. They saw that this happened in intraductal carcinoma, and they actually also saw that this happens sometimes in high-grade PIN, which was what was really interesting about this study, that not all high-grade PIN is a precursor lesion. It usually is, but some high-grade PIN does represent retrograde spread as well. So it was, you know, kind of interesting, but this also supports the notion that intraductal carcinoma does arise from the neighboring adjacent invasive carcinoma. Another study that highlights potential evidence for intraductal carcinoma representing tumor progression is this really great study. Even though it was one case, these authors sequenced 25 different areas of the prostate with tumor. So all different areas: seminal vesicle invasion, extraprostatic extension, different regions of the prostate. And they examined this by a low-pass whole genome sequencing and whole exome sequencing. Based on copy number analysis and all of the sequencing, they were able to make these phylogenetic tree on the branch points of prostate cancer progression. And what they found was that when they sequenced the lymph node metastases bilaterally that this patient had, they found that the lymph node metastases were the most similarly molecularly to the intraductal carcinoma within the prostate, which is really interesting, right? Because it seems like that what was in the ducts was actually most similar to what actually metastasized. I think it sort of suggests that the spread of this intraductal carcinoma is the latest kind of the latest evolution of this tumor that then has the potential to metastasize to a distant location. So, you know, it's perhaps something that lets these tumors enter the ducts is also what potentially makes them metastasize, which I think is really interesting. Another example of, so just moving on to clinically speaking, intraductal carcinoma definitely is a harbinger of aggressive disease. So in biopsies and radical prostatectomies, intraductal often emerges as an independent predictor of poor prognosis, and independent of Gleason grade and stage sometimes. Intraductal carcinoma is associated with decreased cancer-specific survival, even among patients with metastatic disease at presentation. And also after definitive therapy for prostate cancer. So even when you look at cohorts of patients that present with metastatic disease that haven't even been treated, those with intraductal found on their core biopsies tend to have a worse survival, which I think is really interesting, and also kind of suggests that intraductal carcinoma does represent a very advanced kind of form of the disease. And so I mentioned before that distinguishing intraductal and invasive cribriform carcinoma isn't usually that critical when you have an abundance of high-grade invasive cancer. And so some studies have started to combine looking at these two together. This is one of the earlier studies by Trudell et al. And she looked at intraductal carcinoma and large cribriform invasive cancer, and they analyzed these together. And what they saw was that any amount of intraductal or large cribriform cancer was associated with an increased biochemical recurrence. Intraductal, and when they actually did try to separate these and analyze them separately, intraductal carcinoma and large cribriform invasive cancer. And when they analyzed them separately, they didn't really see a difference in biochemical occurrence. Although I will point out that this dotted line here represents intraductal cancer in the absence of large cribriform cancer, and it does seem to have a little bit of a worse prognosis, although this wasn't statistically significant. And so together, intraductal cancer, intraductal carcinoma, and invasive cribriform carcinoma are associated with a worse clinical outcome in prostate cancer. It's predictive of postoperative metastasis, also disease-specific survival. And typically, and actually these three studies in modern pathology by Queldam have shown that actually the presence of intraductal carcinoma and invasive cribriform carcinoma outperform reporting percentage Gleason pattern 4 on biopsies for predicting clinical outcome. And so both recent guidelines by, sorry, let me just, I forgot to silence my phone. Recent guidelines by ISUP and GUPS have recommended, which are coming out shortly, are recommending that we report intraductal carcinoma and or invasive cribriform carcinoma when we see this present in core biopsies, just because it does have such a strong prognostic importance. Another really large study looking at intraductal carcinoma and invasive cribriform carcinoma by Chua et al. They looked at over 1,300 cases. It was a multi-institutional study, and they found that cases that had either intraductal carcinoma or invasive cribriform carcinoma independently predicted biochemical recurrence. They found that these cases, in comparison to those without, had an increased percentage of genome alteration by copy number analysis, and also increased tumor hypoxia. They also identified a new long non-coding RNA, SHLAP1, which was expressed in higher amounts in the cases with intraductal carcinoma and cribriform carcinoma. And in other studies prior to this, SHLAP1 has been shown to independently predict lethal prostate cancer. So just another molecular feature of intraductal carcinoma and invasive cribriform cancer that might somehow lend itself to developing worse prognosis. So what about the cases of rare cases of intraductal carcinoma observed in the absence of invasive disease? And these cases are very, very few and far between, but you can think that perhaps a subset of intraductal carcinoma represents a precursor lesion to invasive high-grade carcinoma. This was a case we had recently of an 84-year-old man who had an elevated PSA. This was an MRI-targeted biopsy, and they found this lesion, and showing a dense cribriform pattern here. We did immunostains and found that this was all intraductal, and he had no other cancer in the case. And so this can be a real dilemma on core biopsy. We do recommend, the current recommendation is to just treat definitively, because these cases are associated with invasive disease on very high grade, high stage at radical prostatectomy. But a lot of clinicians are, feel a little wary of resecting a tumor that's completely non-invasive. Although, again, I think, definitive therapy is definitely warranted because of the high association with high-grade disease. And in these studies, published by both my colleague Brian Robinson and myself, where he looked at intraductal carcinoma on core biopsies without any invasive cancer. And again, most of these cases had very high-grade disease. 90% had very high-grade disease, high-stage disease. More than half were over T3A. And there was also a very high rate of progression after treatment. In the study that I had done with looking at intraductal carcinoma on core biopsy with only low-grade cancer, so Gleason 6 disease, most of these cases at radical did also have higher grade, higher Gleason scores, higher stage of disease, and also a high rate of progression. So definitely makes the case for definitive therapy being warranted in cases where there's just intraductal carcinoma. But I think what was really interesting about these studies was not the main finding. If you kind of dig deeper into the results of both of them, you'll see that actually 10% of the radical prostatectomies in this first study had no invasive cancer. So the radical prostatectomies, some of them were entirely submitted and they didn't see any invasive cancer, just intraductal carcinoma. Similarly, in the study that I did, we found that 20% of the radicals only had low-grade disease in the background, so just a grade group 1, and then intraductal carcinoma as well. And so I think that this is morphologic evidence that intraductal carcinoma may be serving as a precursor lesion. And this is another study that also supports this in Miai et al., looking at intraductal carcinoma that was located distantly from invasive disease in radical prostatectomy specimens. And they found that in these cases, they had a good prognosis after radical prostatectomy. They were the first to term, regular type intraductal carcinoma, which was far more common. They saw this in 141 of the 900 radical prostatectomies they looked at. So that's intraductal carcinoma with abundant high-grade disease in the background. And precursor-like was what they termed intraductal carcinoma that was separate from invasive cancer, they found was a lot more rare, so only 14 of their cases. But just some evidence that there's a good prognosis. So coming back to this sort of paradigm, we think that there's pretty strong evidence for high-grade invasive Gleason pattern 4 and 5 to have retrograde spread to form intraductal carcinoma. There is very good evidence, which I didn't talk about today, though, molecular evidence for high-grade PIN being a precursor lesion to low-grade invasive cancer. We think that low-grade cancer may be can progress to high-grade cancer, although this hasn't definitively been proven either. And so there's also kind of a question of whether high-grade PIN can evolve into intraductal carcinoma. Certainly we have those borderline lesions, which would suggest that there's a spectrum here, and maybe they kind of evolve into one another. Maybe intraductal can arise de novo from some other, just kind of arises by itself. And maybe in some very rare cases, intraductal carcinoma can then become invasive high-grade cancer. And so that's a pathogenesis possibility with this lesion. So I think moving on to just issues in reporting and grading, since I think this presents a lot of problems for us as pathologists sometimes, and there's definitely a lot of debate in this area. Reporting intraductal carcinoma, strong evidence again for recommending definitive therapy, even in the absence of high-grade invasive disease on core. And then there's obviously been very differing opinions on how best to report the lesion. Do we incorporate intraductal carcinoma into the Gleason grading schema or not? And definitely this is controversial at this time. There's been a lot of editorial debates on this topic, which you can see. And if we incorporate Gleason intraductal carcinoma, it would kind of fit into our current grading schema. These are all the reasons in favor of grading it. Gleason pattern 4 is already defined, cribriform pattern is defined as Gleason pattern 4 and 5 if there's solid nested necrosis. So we can easily fit intraductal carcinoma with these different morphologies into Gleason patterns 4 and 5. Certainly most cases with intraductal cancer on biopsy have much higher Gleason scores at radical. So if we're recommending to treat intraductal cancer as if there's high-grade invasive cancer present, why not grade it as high-grade? Certainly makes a lot of sense. I think sometimes, it's also difficult to distinguish high-grade invasive cancer from invasive cribriform cancer on H&E, and you do need immunostains to really distinguish them. So in order to eliminate the use of those, not grading intraductal carcinoma as the same as invasive cribriform cancer is reasonable. Also, the presence of necrosis being Gleason pattern 5, that in the development of the Gleason grading system, it often, because you definitely see comedonecrosis in intraductal carcinoma, that was probably what was graded as pattern 5 when we said necrosis is part of Gleason pattern 5. So why are we then eliminating intraductal carcinoma from the grading system when that was originally what was included when we talked about necrosis? So these arguments definitely all make sense. But against grading is the fact that in situ carcinomas, anything surrounded by a basement membrane in other organ systems is not graded using the same system as the invasive component. If you think about the breast or any other organ system, we don't grade DCIS the same way as we grade an invasive breast cancer. Rare cases where, again, intraductal is identified in the absence of invasive disease, you can get an incorrect categorization of patients as having a high-grade invasive cancer and a worse prognosis. And patients with only intraductal carcinoma at radical prostatectomy are effectively cured, and grading those as a very high-grade cancer may be a little bit misleading. Again, these cases are rare, but this was a radical prostatectomy we had at our institution, which was graded in the past as Gleason 4 + 5 = 9, because there's dense cribriform growth and comedonecrosis. But this actually was all intraductal. It was organ confined, and we did some immunos, and basically the tumor was all intraductal, and this patient was essentially cured. So telling your clinicians that they have this high-grade cancer at radical prostatectomy when it's all a precursor lesion could be misleading. Again, these cases are very rare and few and far between. So you could also argue that if you grade them and you miss some of these, it's not, the biggest deal, especially if the prostate's already out. So what's a practical approach to grading? The good news is that intraductal carcinoma is typically focal. We typically, it's so focal that when you incorporate it into Gleason grading, it doesn't usually change the grade of the biopsy or radical prostatectomy. So I think that, if there's no high-grade invasive disease that's obvious, then I don't grade it, and, I report it separately, and I'll do the IHC in these rare cases where it's important to know if it's all intraductal or not. If grading intraductal cancer does change the overall Gleason grade, it's definitely controversial on what to do. I would say that, the most important thing is to really to be sure that your clinicians know that intraductal is associated with aggressive disease. I know my urologists at our institution, when I put intraductal in a report, they tell me we don't even look at the Gleason grade. We just know that that's going to kind of trump be the deciding factor in a worse prognosis. So essentially, as long as your clinicians kind of know that this is aggressive cancer, that's the main point here. And so just a little bit on the current research that I've been doing. And I do want to mention a little bit about a word about precursor lesions. We had published some review articles on pre-invasive neoplasia in a section of Archives, Pathology in Laboratory Medicine a few years ago from our institution. And in the intro section, one of our faculty members, Dr. Borzek, from our department, emphasizes the need for pathologists to lead the exploration into this frontier. We, as pathologists, are the only ones that really recognize and see precursor lesions in pathology, and so we're the people that can really study this. You know, a lot of cancer research today is focused on a lot of oncologists will study metastatic lesions in the most advanced cases, but we're in a position where we can actually see precursor lesions and can study them molecularly and discover, you know, all kinds of things about how disease evolves. And so one of the studies I just want to touch on briefly that I had done over the past couple of years was this study on intraductal carcinoma in the absence of high-grade invasive cancer. And we looked at 15 total cases of radical prostatectomies that had just invasive intraductal carcinoma with no invasive cancer, and 11 radical prostatectomies that had, 11 of these had just low-grade cancer, so just grade group 1, Gleason score 6. And 15 total cases in this study, and we actually found some really interesting results molecularly. So the first thing was that we looked at PTEN and ERG status. Now remember I said in the studies that were done previously, ERG and PTEN are usually present in, ERG overexpression and PTEN loss are usually present in intraductal cancer with a lot of invasive cancer, high-grade invasive cancer in the background. So in prior studies, 60% and up to 86% with PTEN loss. In our study, however, without high-grade invasive cancer in the background, only 7% of these cases only one case had ERG overexpression, and a lot of them still had PTEN loss, but these are significantly different. So the cases without high-grade invasive cancer in the background seem to be molecularly different. This is showing an H&E from one of these cases with just intraductal carcinoma. Actually, Dr. Wabker at UNC Chapel Hill contributed this case, and this really nice photo of intraductal cancer. And when we did PTEN immunostain, we see loss of PTEN within the tumor and nice internal control in the background. So we also saw frequent PTEN and ERG discordance between the low grade, so the cases that had some Gleason 6 in the background, showed a lot of discordance between either PTEN or ERG, which suggests that they're not really clonal. Remember I said ERG usually happens first and then PTEN comes later, but if you have a lesion with, you know, a Gleason 6 cancer with ERG overexpression and no PTEN loss, and then the intraductal cancer has PTEN loss without ERG, this shows that they're clonally unrelated. So typically, you don't see this discordance in intraductal and high-grade cancers. You only see about 7% of cases with discordance, according to a prior study. So this high rate of discordance actually suggests that this intraductal cancer is not related to low-grade cancer. It's probably more likely related to the high-grade cancer that, you know, presumably would develop later. And then what was really interesting about these cases was in the absence of intraductal carcinoma, in the absence of high-grade invasive disease, they had some unique molecular features. In the MAPK and PI3 kinase pathway, now these are genes that are almost, I would say, point mutations in prostate cancer are pretty rare overall, and we saw an enrichment of point mutations, activating mutations in the MAPK pathway and the PI3 kinase pathway. Again, very rare if you look at TCGA and all these published cohorts, activating driver mutations in BRAF, KRAS, MAP2K1. These are almost unheard of in prostate cancer. Like less than 2% of cases have these mutations, and we saw such a significant enrichment. We also saw features that are indicative of high-grade disease, RB1 loss, c-MYC amplification in a lot of these cases, suggesting that these are truly aggressive cancers, but they haven't become invasive yet. So perhaps a precursor lesion, potentially precursor lesion to a high-grade phenotype. Also of note, MAPK alterations in the BRAF and KRAS pathways, these are known to be targetable in other malignancies. So it also suggests that maybe these very rare variants, this very rare variant of prostate cancer is targetable. So in conclusion, from the study, we found that intraductal carcinoma without high-grade invasive cancer in the background appears to be molecularly distinct from conventional intraductal cancer. They can show PTEN loss, but they're typically ERG negative, and we do see an enrichment of mutations in these MAPK and PI3 kinase pathways. Frequent discordance from intraductal and Gleason 6 cancers suggests that these lesions arise from separate clones, and also that a subset of these intraductal cancers are likely to be true precursor entities that possibly lead to aggressive invasive disease if left untreated. Future directions with this, there are mouse models of prostate cancer that exist with constitutively active genes in the MAPK pathway. So I'm currently trying to collect more cases of prostate cancer with these rare mutations. If you have any, I'd be love to collaborate if you want to send some tissue. Looking to compare these cases to the mouse models and see if there are similarities morphologically and also molecularly. One of the criticisms of even using these mouse models to study prostate cancer is that human prostate cancers don't usually have those mutations, but here we do have some cases that do show those mutations, and maybe those models help model this kind of rare type of prostate cancer. So I'm also, going forward, performing more molecular assays on intraductal carcinoma and adjacent high-grade invasive cancer to kind of further interrogate molecular pathogenesis. There's some preliminary data out there at USCAP that we presented a poster on looking at this in a preliminary way, which I don't have time to get into here. But take-home points are that most intraductal cancer, again, represents retrograde spread of invasive cancer along prostatic ducts, and it is a harbinger of aggressive disease. Should always be reported when it's present. Always avoid the benign pitfalls in diagnosis, and you want to keep a very high threshold for calling it on biopsy as definitive therapy is warranted. And then also just to keep in mind that a subset of intraductal carcinoma seems to be precursor-like and has a distinct molecular pathogenesis from conventional intraductal carcinoma. So when you do see it in the absence of abundant high-grade disease, it might be worth doing an immunostain and just proving that. So any questions? I think you can just type the questions into the Zoom chat and be happy to answer.
Thanks, Dr. Khani. So there have been a couple questions. If you have more questions, please go ahead and enter them in the chat. But I have one that came from a Steve Long, and they're asking, when do you do PIN immunostains?
PIN immunostains. Oh, so a PIN 4, do they mean a PIN 4, I assume?
I assume. Okay.
So I only do the stains if I think that if I have a question about whether there is truly invasive high-grade cancer present. And these are very, very rare cases. I mean, over a year in practice, I maybe stain a handful, like 5 or 6 cases where I think that it could be all intraductal and there might not be any high-grade invasive cancer, just to be accurate in the reporting of what's actually there. But in the vast majority of cases, I don't recommend doing immunostains. I think it's excessive to do them on every case with intraductal, certainly, especially when it doesn't affect the grade of the tumor.
All right, so the next question from Michael Aguelo. Francesca, given how similar they are, is intraductal a precursor of ductal adenocarcinoma?
So I don't think that it's a precursor of ductal adenocarcinoma. I do think that they are similar, and there are actually some molecular similarities between intraductal and ductal. There was a recent study of ductal adenocarcinomas that also found a little bit of an enrichment of MAPK alterations. But I don't think that these necessarily lead to one another. It's certainly possible. We really just don't know. We do see them together, though. Sometimes you do see cases that have intraductal and ductal, or sometimes ductal growing within ducts, as I mentioned before. But whether one truly leads to another, I think we don't have any evidence for.
Yes, definitely there's a lot of opportunities here for studying the molecular of these. We have another question that's come in from Russell Broadus. Why do you think these high-grade cancer cells grow in the ducts? Is this by accident, or does growing in the ducts give the cells a growth advantage?
Yeah, I think that's a terrific question. I really want to know that. I think that somehow growing within the ducts probably does give the cells some sort of advantage. I don't know what that is. I don't know, I think that's something that would be really interesting to look into. But we just don't know why. Yeah, I think, but I do think that's a really interesting, line of questioning. I think certainly the one study that looked at a lot of intraductal and cribriform cancers, they found, an association with tumor hypoxia, um, being able to grow kind of without an oxygen supply of the blood vessels in the stroma. I don't know if this is related, but I think it's a very interesting point, and something that we should continue to look into, whether they really do have an advantage, or even just the fact that the cells can break through a basement membrane again. Does that give them some sort of, are they more aggressive just because they've been able to do that and then are able to metastasize? I don't know. But it's interesting. I mean, I do think, yeah, I mean, it is very interesting, and there aren't, a lot of other organ systems we don't really see this. Aside from maybe the pancreas, do we see, cells that invade the stroma and then go back into ducts? It's not a very common or, pathway of least resistance, so to speak.
All right, so we got a couple more that have just come in from Peter Sato. This is a long one.
The issue, of course, is with cribriform pattern and with comedo-necrosis on core, which I would call 4-5. Now it makes me wonder how many times I've overcalled intraductal, as I would typically not order basal markers on those cases. Would you order on every case with cribriform with comedo-type necrosis, especially if absent single? Yeah. Thank you for your question, Peter. I think that, this is a really tough thing. I think we all struggle with this. My sense is that, normally when I see cases with comedo-necrosis on core, usually I try to just find an area that is invasive, that's definitely invasive, that has those same features, hopefully invasive with some necrosis or just some single cell pattern 5. And I do find that in a lot of cases, it doesn't really alter the grading. So even if you were to do the immunostains, you'd find that a lot of it's intraductal, a lot of it isn't, and you would usually come up with the same grade generally. I think it's a tough question. I think that I think ordering it on every case is definitely excessive. I don't do that myself. Again, I really restrict my use of immunos to cases where I think that there truly is a possibility that some of it is not invasive at all, or if there's only low-grade invasive in the background. But I think that I definitely wouldn't order it on every case of cribriform with comedo-type necrosis. I think especially when you have invasive cancer that's of a similar grade outside of those lesions, then there's really no harm in just calling it 4-5-9 and reporting that there's cribriform and or intraductal growth in the core as well, if that answers the question. It's a tough thing because I think it's controversial and we don't have, great evidence for doing it one way or the other right now.
Great. All right, so we'll make this our last question. We're about 5 minutes over. From Jordan Reynolds, have you or do you currently include some kind of comment when you sign out a case as only IDC-P?
Yes, great question. I do. I think especially, if your clinicians aren't, if your clinicians aren't familiar with this entity, or if you don't know if the clinician knows, I do put a comment if it's only intraductal carcinoma that will say that most of these cases that, radical prostatectomy are associated with high-grade invasive cancers. However, a very rare subset, in about 10 to 20% of cases, will you see no invasive cancer in the background. However, definitive therapy is definitely still warranted in these cases, given the definitive therapy, or at minimum, a repeat biopsy to detect other invasive cancer would be recommended. So I do put a note. I think it's important. I think a lot of our clinical colleagues don't really understand the nuances sometimes of this. So really spelling it out in the reports is very helpful, and making sure the patient gets the right treatment.
Okay, I think we'll wrap it up there. Thank you, everybody, for participating. Thank you, Dr. Khani, for giving us a really excellent lecture. And I think this is a really wonderful way to kind of keep in touch with all the various academic endeavors for people in pathology and disseminate it widely. So really excited to have everybody here. Please fill out the evaluation form so we can get some feedback and continue to improve this. But thanks again.
I do have, if anyone still wants to stay an extra second, the last question was also really interesting. If I could.
Sure, I won't shut it down.
Yeah, no, by Kartik Viswanathan. He had said, this is an unusual question, but is there a possibility that intraductal carcinoma could be picked up on urine cytology? And I also think this is really interesting. Being that it does grow within the ducts, it's conceivable that some of these cells might enter the urine through the prostatic urethra. I don't know if it's ever really been reported. I don't think it has, but I think it's certainly possible. We do see prostate cancer in urine specimens, and I think it would be interesting to see if those cases maybe had intraductal more commonly. But certainly, I think, it's an interesting point that maybe cases with intraductal would be more likely to be picked up in a urine cytology. So just thought I'd bring that up.
Great. Thanks, guys. Have a good day.
Thank you. Thanks for coming.